So good morning, everyone. We are going to begin. My name is Beth Ann Turnavin. I'm the clinical supervisor at Family Services Windsor Essex Counseling Program in EAP. I'd like to welcome everyone to our speaker series this morning, our clinical speaker series. And our inaugural or first seminar is going to be about the current best practices with regards to eating disorder treatment. So just a couple of items very quickly. I want to acknowledge that we are joining you from the traditional territory of the Three Fires Confederacy of First Nations, comprised of the Ojibwe, the Ottawa, and the Potawatomi. I'd like to invite you to submit questions to our chat, and myself and my colleague Allison Prier. We're going to be monitoring those questions in the chat throughout, and we will reserve as much time as we can towards the end to take your questions. And also additionally, for those of you that can hang on the call a little bit longer past 10 o'clock, Jennifer has agreed to stay on a little bit longer and have those conversations with you. So we're very grateful. To get started, I'd like to introduce Luciana Rosu Cieza. As many of you know, she is the executive director of the Bulimia, Anorexia, Nervosa Association. Luciana graduated from the University of Windsor in psychology. She started at Banna in 2004 as the health promotion manager, was then elevated to the interim executive director in 2012, and is now for many years the permanent executive director at Banna. She is a wife, a mother, a leader, an educator, and a motivator, and we are thrilled to have her introduce our speaker today, Jennifer White. Luciana, over to you.
All right, thank you so much. Well, it's a real pleasure to be here today to introduce Jennifer White. I have had the pleasure of working with Jennifer in sitting on panels and doing some media interviews. So it's a real pleasure to introduce you, Jennifer. So Jennifer White is a registered social worker specializing in individual psychotherapy. She's a graduate of the Masters of Social Work program at Wayne State University in Detroit, Michigan. Jennifer White is passionate about continually staying on top of current best practice modalities for psychotherapy. Jennifer has also holds an honors Bachelor's of Commerce degree from the University of Windsor and a Bachelor of Arts degree in Political Science from McMaster University in Hamilton, Ontario. Jennifer has specialized her counseling services in the area of eating disorders, most recently as a therapist and social worker at Paragon Psychology in Walkerville. After spending 8 years of her career at the Windsor Essex Community Health Centre's Teen Health Site in Windsor, Ontario, Jennifer has devoted her career to helping individuals suffering with eating disorders and their loved ones restore control of their lives. She structures her treatment on evidence-based practices that are designed specifically to meet the individual's needs. In addition to her psychotherapy practice, Jennifer provides consultation and supervision to her colleagues and participates in speaking engagements on topics related to adolescent development, mental health, and body image. She has also conducted seminars and workshops for caregivers and loved ones for those with eating disorders and mental health challenges throughout Essex County. Jennifer is a native of Windsor, Ontario, where she lives with her husband, Sean, and her 2 young adult children and her dog. She has spent years volunteering and being an active member of the Parent Advisory Council of her children's schools and is currently on the board of the Art Gallery of Windsor. In her spare time, she enjoys running, reading, and traveling. So welcome, Jennifer. We're really excited to have you.
Thanks so much. Thanks to both Beth Ann and Luciana for such a warm welcome. I very much appreciate it. So as you all know, this is a first in a series. I've partnered with Family Service Windsor with the goal of, a short-term goal of creating more opportunities for connection in the pandemic, but a long-term goal of bringing low-cost, high-quality training to Windsor. And we're really hoping that, this is going to kick off a really long relationship and opportunities in the future. So because this is a meaty topic, I'm going to sort of dive right in. So basically, there are 4 different types of treatment that we're going to be focusing on today in this presentation. The first two I'm going to spend the most time on, okay? So those are family-based treatment for youth and cognitive behavioral therapy for eating disorders, which is more of an adult best practice modality. We're going to talk a little bit about acceptance and commitment therapy for body image, and emotion-focused family therapy, which is an adjunct in the family-based treatment model. Okay, so the first thing that is, often comes up with eating disorders is that it is the most treatment resistant of all psychiatric diagnoses. And, part of why we're doing this today is that I think it's my observation, and for those of you who work in the eating disorder field along with me, it really seems that eating disorders get a bit of a bad rap. A lot of clinicians will shy away. And part of, why we want to shed light on this is to remove some of the stigma and make this a much more approachable population to work with. So, in that vein, why do they have the reputation for being so treatment resistant? The primary reason is that depending on the diagnosis, it is either egosyntonic or ego dystonic. So, in this presentation, I'm not really going to focus so much on the actual diagnoses. If you are a clinician, which I'm assuming that most of you are, you already understand what those diagnoses are. So we're not going to dive too heavily into that. And you're probably familiar with some of these other terms as well. But in particular, when we have more restrictive type of eating disorders like anorexia nervosa or even ARFID, so that's just restrictive eating without the drive for thinness, we find that the client, part of them is very almost proud of what they're able to accomplish within the disorder. So the lack of insight, which is one of the symptoms, drives a thought process that makes the behavior very comfortable. And so it gives them a sense of self-esteem when they can be more restrictive with their eating than some of the other people that they know or in their lives, or they can maintain a lower weight or a healthier diet for those who have more orthorexic or healthy eating type of restrictive patterns. So by egosyntonic, they do feel the disorder helps them feel good in certain ways. And so they are less likely to seek treatment or less likely to be motivated for treatment. In other types of presentations like binge eating disorder and bulimia, we do have disorders that are egosyntonic, which means that the client has a lot of shame around their behavior. And so for that reason, even if they're more likely to initiate treatment, but once they're in treatment, they're less likely to want to be fully forthcoming about all of the behaviors because they do feel so much shame and embarrassment about what happens. So both of those orientations really give us barriers to treatment. We do know that eating disorders are physically, neurologically, behaviorally, and emotionally reinforcing of one another. So unlike some of our more standard psychiatric diagnoses, their behavioral component is so entrenched that it really creates a lot of self-reinforcing cycles that clients can get trapped in. And eating disorders also have a very high comorbidity with other types of diagnoses like obsessive compulsive disorder, anxiety, depression, and trauma. So all of these things make it sort of difficult to treat. Just a bit of a side note here. A lot of, I think, both clients and their families get very stuck on, like, what came first, the chicken or the egg sort of thing. And regardless of the type of treatment that we're going to talk about here, in particular, the family-based therapy or cognitive behavioral therapy for eating disorders, we, especially at the outset of treatment, we are not overly concerned about what started the ball rolling in the first place as we begin treatment. So parents in particular, I find, are like, what started this? How did this happen? Don't we have to get to the root of the problem? And in treatment, I do use an analogy of cancer quite a bit. It's not a perfect analogy, but it is something that we can all relate to that's a little bit more concrete than a mental illness. And so, often what I will say to clients or what I will say to families is, if you had lung cancer and it probably started from smoking, we're not going to say stop smoking and then your cancer is going to get better. Similarly, whatever got this ball rolling in the first place, sure, we're going to go back and look at it at some point, but dealing with that primary sort of precipitating factor isn't going to be what cures you. Food is really the answer, and normalizing the relationship with food, regardless of the mode of treatment. Okay, so the essential components, I really wish you could see my slide. It's all laid out very nicely for you. You'll see it eventually, but right now we're going to talk about the essential components of eating disorder treatment, regardless of which modality you are using. So the essential components that are really important in eating disorder treatment are primarily, we want to separate the eating disorder from the client themselves and really create a separate identity for the eating disorder versus the client. We all know in psychotherapy, the closer something is to you, if you don't have any distance from something, you really can't change your relationship for it. So that is always a first goal. Not only that, but because we are always utilizing some kind of a support network, it is much easier for friends and family to be supportive of the individual if they can also see the separation, because, like addictions and all kinds of other mental health issues, a lot of the symptoms of the disease occur within relationships. And of course, eating disorders want to divide and conquer. So it's helpful for both the client and their family if they can distinguish between the two. Not only that, but because we know that eating disorders so often strike in adolescence, this is a time in life where the client is usually forming their sense of identity. And we really want to be careful that the eating disorder does not become part of that client's identity. So it's very important early on that we create that separation. Another very important component is setting a framework for support. I think it's very commonly known now in the eating disorder world that maybe it's possible for clients to recover on their own. But personally, I haven't really met anybody who has been able to do that. I'm sure they exist. Obviously, my position is a little bit biased because, my clientele are self-selecting, but the element of support is incredibly, incredibly important because the behavioral aspects of the disease are so entrenched typically by the time the client comes into treatment. Regardless of the modality, you also want to acknowledge the perils of what we call the dieting mindset, okay? And that means having a very, very black and white relationship with food. And again, regardless of whether the client presents with anorexia nervosa, bulimia nervosa, binge eating disorder, or a sort of not otherwise specified type of eating disorder diagnosis, their relationship with food, oftentimes they relate to feeling very black and white, very all or nothing. And that dieting mindset is oftentimes what will really drive the eating disorder and keep it going. The other thing that clients need to know is that regardless of whether they're coming in at a low weight or whether they're coming in at a normal weight, they really do need to normalize their relationship with food primarily. And food is medicine. So it is actually normalizing their relationship with food is going to have a very, very curative effect. I see it from both clients and from families that really kind of want to deal with some of the other presenting complaints first, like addressing body image or addressing anxiety or, addressing depression. But the reality is that without that eating disorder and relationship with food being normalized, it will really hijack trying to address any other issues if we don't normalize the relationship with food first. Hope is essential. This is another sort of, I guess, result of stigma in the field of eating disorders, is that I do have a lot of people coming in, families in particular, even other, mental health and medical professionals that will say, oftentimes, they'll kind of squinch their face and say, do people ever really recover from eating disorders? And my answer is yes. Overall, statistically, we can make some very clunky predictions about this. It's sort of the guideline that if, for every year that a client has been sick with their eating disorder, their chances of a long-term recovery go down by about 10%. That is improving as our modalities improve. But statistics are statistics, and they don't tell us anything about individuals. So, sure, if we catch it in the first year, like anything else, like a cancer, if it's allowed to progress, your chances of getting a handle on it aren't as great. In the first year, we basically have a 90% anticipation of a long-term recovery. After about 10 years, that goes way down. But I have had clients who have had their eating disorders for even 15 or 20 years, and they have still managed to recover. The other really beautiful thing about eating disorder treatment is that recovery does look different for every individual. And part of the treatment process means that that client gets to define for themselves what they want their recovery to be and what it's going to look like. So we really want to give the clients a lot of hope and sustain hope along the treatment journey, because, treatment, like anything else, doesn't go perfectly. And so, we want to keep hope alive, and that's a very important element of treatment. Also, the therapist stance must be very empathetic, but we also have to be firm at the same time, because a lot of the eating disorder cognitions are very, very strong and very entrenched. And so as a therapist in the eating disorder world, you want to be really confident that challenging these these cognitions and these ideas and these ways of living is the right thing to do. Okay, so first of all, we are going to talk about family-based treatments. So this is the current best practice modality for youth ages 10 to 17. I have read papers as young as, clients as young as 8 or 9. And in my experience, family-based therapy works well for ARFID, it works well for anorexia or nervosa, and there are some slight alterations for bulimia, but in this age group, this is where we want to start. So family-based therapy is exactly what it sounds like. The whole family is involved in the whole treatment process, particularly phases 1 and 2. In phase 3, which I will explain, there's a little bit more individual time. Okay, so phase 1 of, actually I should say before I go on to that, the characteristics of family-based therapy are that it empowers the parents as being the experts on their family. It takes a very agnostic view of the illness, and it also has that component of externalizing the eating disorder. So, when I was in graduate school, I think we're going to spend more time today talking about eating disorder treatment than I think I did in my entire MSW. So hopefully that changes in the future. Different topic for a different day, but my education was definitely more pathologizing of families. I was sort of taught, well, an anorexic client is the narcissistic extension of the mother, and, the child hasn't been able to individuate, and you need to get the kids away from the parents, and that's how you treat them. And in actual fact, exactly the opposite is true. So, instead of being parent blaming, in the treatment manual, there will be, you can't see the slides. So eventually when you get copies of the slides, all of the books that I'm referring to and, any kind of resources are on the last 2 slides. So don't worry about trying to get this down. But there is a treatment manual for family-based treatment that has been published, and the authors do a really nice job of kind of explaining, how really, if you are the parents of a child who has not been eating, is losing more and more weight, and you've dragged them around to, therapist and doctor, and, family members are making comments to you about, your child not being well and whatnot, you too would also appear fairly frazzled and neurotic by the time you actually got, onto the right track of treatment. So it really encourages the clinicians to be very empathetic of these families, assuming the best, and partnering with them and the client against the eating disorder. So family-based therapy is evidence-based. Again, you are all clinicians, you know what that means. So I'm not really going to spend a whole lot of time talking about the research, but there is a little bit of it in the slides when you do get them. So, things to look forward to. So basically, phase 1 of family-based therapy is where the clinician meets with the family in their entirety. And in today's very busy, time-starved families, this has actually been a lot easier in COVID, getting the whole family to participate. But it's, it takes some convincing that it's really, really important that we include everybody. So that first appointment involves the whole family coming as a unit into treatment. The client, I think a lot of the times the parents are really worried about, how the client's going to feel about this. But it often goes, I think, a lot better than the parents, think it's going to go. So basically, the other thing, if you go for family-based treatment training, it is really interesting because the first 3 sessions are absolutely the most important. And so the bulk of the training itself, the 2 days of training, is spent on these first 3 sessions. And I will agree, in my clinical experience, there have been, the odd time where maybe I haven't set the stage as well as I should have for whatever reason. The client appeared a lot healthier, at intake, really, thought this was more of like a blip. And it's always kind of come back to haunt me if that first session isn't as robust as it needs to be in setting the stage of how serious the eating disorder is. Because not only does the eating disorder rob the client of insight into the seriousness of their illness, they always have this tendency to think, it's not that bad, I'm not that sick, other people have it a lot worse than I do, and that creates a real treatment barrier. Oftentimes the family as well, there's kind of split on it. Part of them is very afraid, but part of them also has a bit of like, oh, well, I'm sure, we'll go to a couple sessions of psychotherapy and this will, get better and off we'll go. So I do let them know straight up that in family-based treatment, in any kind of treatment, really, you're probably looking at a year, of treatment, and that it is very, very intense. As mental health clinicians, I think we are so accustomed to building a rapport. We're so kind and approachable that can actually be a bit of a handicap in the first session. We're not really trained to use fear as a motivator at all. And so I think a lot of us are very uncomfortable with that. But in family-based treatment and in the first session, it's absolutely necessary. And, in my mind, I don't remember if I, picked this up somewhere, if I just called it that myself, but the idea is to give the family what I call the scary speech. So that is like, eating disorders are deadly. They are the most deadly. They are the most treatment resistant. And if you don't all get, really on board with this and take it very, very seriously and devote your life to it for the next foreseeable future, that's the biggest component to having a good outcome. So that it's very important to sort of start off on that. And in the first session, I also do take the history from every person who is present. So, the client will talk about their experience, the parents will talk about their experience, and it's always really the most interesting to hear from the siblings or sibling, if there are any in that family, because they often have a very, very accurate and perceptive sort of idea of, what has been going on in the household. So I do orchestrate an intense scene that discusses the danger of the eating disorder and the difficulties with recovery. And I do prepare the family that typically session 2 is going to involve a family meal. Now, I'd gotten away from that in COVID, but actually I'm sort of going back to it now, because what is easier than like setting up the family laptop at the family dinner table? This sort of happened by accident a week or two ago. I had a session with a family that was sort of going awry, and the client ended up bolting from the session, and the mom was like chasing her through the house, carrying me in the laptop, and it ended at the table with the snack, and it was like, well, I'm here, let's just do this. How does this usually go? So it was then it sort of clicked to me, like, actually, it's probably really important that we get back to doing the family meal. And I might always do it, over video. So that, family meal is a very important part, because it's a very good opportunity to coach parents in real time through the difficulties with eating. So the first session, we also, we externalize the eating disorder. Probably the hardest thing for everybody to wrap their heads around in that first session is that the parents are charged with refeeding their child. So phase 1 is all about nutritional and physical rehabilitation of the client. We acknowledge that whether it is anorexia nervosa or a restrictive eating pattern or bulimia, until that relationship with food is normalized and until that client is weight restored, there really isn't any use in trying to address any other issues, because the brain is 20% fat. And if the body is at all in a crisis mode, either from being underweight or from very disrupted eating patterns, they are not going to be a good candidate for standard talk therapy in any way. So phase 1, session 1, we are charging the parents with refeeding. You can imagine you can think about it like exposure therapy, basically. So, as we are normalizing the eating pattern and as we charge the parents with refeeding, it is the parent's job. And basically we sort of give them permission to use their best judgment. You are the expert on your family. You are the expert on your child. You have good common sense. You have fed everybody very successfully until this point. So, you are in charge. And even the clients who are resistant to being in treatment do recognize that this is necessary. So that client is very conflicted, but we sort of use a bullying analogy and allow the parents to see, and I'll often work with the client on this, on sort of demonstrating what the eating disorder pathology sounds like in the client's mind, so the parents understand that at mealtime, the eating disorder voice and thinking process is so loud in the client's mind that it is actually a relief for them. It reduces a lot of anxiety when the client knows that they no longer have to make their food and eating choices, and that the parents will be making it for them. Now, the eating disorder will get very angry. Typically, clients are very, very compliant in the first few sessions, because I think they kind of think, you know what, I'm going to go along with it. I'm going to give the grownups a sense of ease. This is the eating disorder talking. The grownups will get off my back, and then, like eating disorder and client can go back to, living their happy life. It's usually not until maybe the 4th or 5th session when the client realizes that we're serious about this and we're not going to give up, that the really significant internal battle between the eating disorder and the client starts, and there we might see a little bit more resistance, and that's where we get into a lot of parent coaching. So phase 1, it's difficult to say prescriptively, but generally speaking, it lasts around 12 weeks. And in the early days, we are looking for a weight restoration, if the client is underweight at presentation, of 1.5 pounds to 2 pounds per week. Weight restoration is ideal. And if the client and their family can accomplish this in the first 4 to 5 weeks of treatment, generally speaking, we know that the chances of a long-term recovery are very, very strong. Also, we do encourage parents to allow the clients or to serve the clients a very wide variety of foods, because regardless of the modality, clients who symptom interrupt and weight restore with a wide variety of foods tend to stay in recovery versus those who, weight restore, normalize more so with their safe foods, have a higher propensity to relapse down the line. Alrighty, so session 2, we do the family meal. Again, when we're in person, I'm weighing the client every session. In COVID, I'm obviously not doing that. So either, we're having the parents weigh the client about once a week, or, I've signed a release with Teen Health or somebody else who's monitoring them medically, and I just get the information that way as far as like how well the client is progressing. So yes, session 2, family meal. It's a good opportunity to get a history of food and eating in the family and with the client in particular. As the clinician, I do not engage in eating with the client and their family. That makes them super uncomfortable. But I guess in COVID, with me being on a screen, that also would make it a lot easier. And it's a good opportunity for me as the clinician to observe how the family interacts at mealtime and how they cope with eating disorder behaviors. So that's pretty much how it progresses. Anxiety around new foods is dealt with as we go along. We introduce cognitive pieces and strategies as we go along the way that can be helpful. And when we get to phase 2, the client is probably, when I was first trained, they said, you can switch to phase 2 when the client is 85% weight restored. Personally, I found that too difficult and the eating disorder a little bit too strong at that point. So, and I think it's since been sort of changed to be like 95 to 100% weight restored. That is when we can switch to phase 2. So phase 2 involves the adolescent to start to take over their food and eating decisions, but it's really, really important. This is a very risky time that it's done with supervision, slowly and methodically in an organized way. And over that phase 2, the client goes from making almost none of their food and eating decisions to all of their food and eating decisions. And then in phase 3, that is when we are moving to addressing anything that could create an opportunity for relapse. So in phase 3, this is when I start working a lot more individually with clients. And we are talking about anxiety, we're talking about depression, we are talking about anything else that was not dealt with in the first 2 phases. And we are particularly spending quite a bit of time, generally speaking, on body image, if this is still a problem that the client is dealing with. Okay. So family-based treatment is wonderful if it works, but it doesn't always. And some of those reasons might be, high comorbidities. It might be that the family, has their own things that are going on that sort of rob them of the ability to follow the structure and whatnot. So cognitive behavioral therapy for eating disorders was first successfully used to treat bulimia in adults, but it is also effective for anorexia. It's effective for binge eating disorder, can be used in the adult or the adolescent population. It recognizes that a main factor in maintaining the eating disorder is the client's attitude towards shape and weight and their overvaluation of weight and shape in their self-concept. The clients, overall, we talk a lot about a tendency to overvalue thinness and control overeating as barriers to recovery. And we know, in our clients that this overvaluation of thinness, overvaluation of weight and shape really does have a very sort of negative impact on mood, self-esteem, raises anxiety, and all of these other things. So CBTE is the short form. It is a manualized treatment. Also, when you get the slides, the treatment manual, like title and author and everything is in there for you as well. It lasts anywhere from 20 to 40 weeks. So the 40-week modality is for clients who are coming in with a BMI of, approximately less than 17.5, or they're just, not at an ideal body weight or even close to it. But for the most part, generally speaking, it's a 20-week treatment plan where the changes are slow and systematic. The key element is the formulation. And what is nice about CBTE is that the authors and researchers have made the training for the treatment, it was their mission to very widely disseminate it. So it is available in an online format. And I believe it's still free. It can be a bit of a pain to get set up with them. But if once you do that, and I think they also ask, you have to have a certain number of eating disorder clients as well that you are treating as you go through the training process. But it's very heavily supported. It's very comprehensive, and it's pretty accessible for clinicians who are interested in getting trained in this modality, as opposed to, family-based therapy where the dissemination has not been as wide. It's quite expensive. I believe they're doing it online now in a webinar or, online format. But it's a little bit more difficult to access the training for FBT. Again, that's something that hopefully changes down the line, but CBTE training is quite accessible. Okay, so a key element is the formulation. So in the slides, you will see just a sort of model of this. So basically it's a diagram, and you work with the client early days on treatment to create their own unique formulation that creates a snapshot of both the precipitating factors to their eating disorder and the maintaining factors. So those factors that keep the eating disorder going. And that snapshot or formulation is something that you're able to refer back to over the course of treatment. And it really does reduce a lot of the client's anxiety, because it's like they can visualize it, they understand how it all works. And as a result, it appears to be a much more approachable problem. Okay, so the other piece of CBTE that is very important is client self-monitoring. Okay, so the client basically early in treatment starts documenting everything that they are eating and the time and the circumstances. And there are, sort of codes or things that they can document if they restrict, if they purge, if they engage in any other kind of compensatory behavior. So the self-monitoring, or basically food journaling, does seem to, I don't really like the idea, right at the outset, understandably, right? And a lot of clients are concerned early in treatment that if I'm writing everything down, will that actually make me feel more shameful or more secretive about my behaviors? And generally speaking, it's been my experience, and I think that a lot of other clinicians too, that inside of the first few days or the first week, it just becomes quite automated. And that sort of preoccupation that they have with the self-monitoring process really does dissipate on its own. So why is self-monitoring important? Sorry, I should say, yes, they self-monitor. It's particularly a focus in the earlier stages of treatment. And then towards the end of the 20 or 40 weeks, we do wean them off of the self-monitoring before they complete treatment. But why is it important? It is important because it increases the client's mindfulness regarding their behavior. One of the main, I would say, challenges with eating disorders, and I think all mental health issues, but to a greater degree in eating disorders, these are diseases of disconnection. disconnection from the client's own hunger cues, disconnection from their body, disconnection from their relationships, from their hobbies, from their social life. It becomes very all-consuming. So the self-monitoring process really starts that reconnection once again by building mindfulness and reducing shame, by approaching these behaviors as something that you did because it worked. So let's understand that there was logic behind this when it all first started. You were trying to help yourself in some way, shape, or form. Let's really understand what this does for you, because if we don't understand that, we can't give you something that's actually going to be better for you in the longer term. The self-monitoring process then, as a result, connects the behavior and emotions, so things that did not seem related in the past. Now we can understand the patterns. It does help to break down that cycle of avoidance and shame. And truth be told, way back in the day, you know, and a lot of facilities still use like a paper sort of monitoring form, which is great. I use an app, which is very convenient for my clients because it's on their phone. So they really don't have any excuse not to complete this monitoring in real time. And of course that's, you know, we tell them early days, like, please don't go back at the end of the day and fill this in. The whole point is that you're doing the self-monitoring as you go along. And that's where the rubber is really going to hit the road as far as increasing our insight and making changes that are going to be sustainable over time. So that is CBTE in a nutshell. Acceptance and commitment therapy is a third generation treatment that we are often maybe using within a vehicle of family-based therapy or even CBTE in addressing body image problems. So what we want to do, or if you have a client with significant body image problems or distortion or dysmorphia, but are at an ideal body weight, ACT, or acceptance and commitment therapy, is a great standalone treatment for body image distortion and body image problems. So it attempts to have the clients separate themselves from the thoughts driving their low self-esteem. So basically, it's like it accepts that a lot of the negative body image thoughts and cognitions are considered automatic thoughts. And just because you have them doesn't really mean that you need to believe them. And we recognize that a lot of these negative body image thoughts and cognitions occupy an undue amount of brain space or emotional bandwidth within our clients that actually really do not align at all with their value system. So what we're trying to do in ACT is acceptance. I accept that I have these negative thoughts about my body, but I commit to spending my emotional energy or my time on that which I value. So the treatment process involves both identifying some of the negative body image thoughts and giving strategies to sort of deal with those, but then aligning the client with their values and making changes in their life so that what is important to them and what they are spending their time and energy on aligns more with their values. So we really have this idea that we are transcending the body image problem or any of these issues related to self-image. And it's, you know, very, very useful. And a lot of clients really respond well to these types of interventions. And there is a brief mention in the slides of UCAN, which is Uniting Couples in the Treatment of Anorexia Nervosa. And I won't really spend a whole lot of time on this other than to let you know it is an evidence-based practice, and it's basically like a form of family-based treatment where the spouse or the partner is mobilized as a main unit of support. Again, you know, there's a sort of not accurate idea that a lot of people who have eating disorders, anorexia or nervosa in particular, don't have partners. And that is not actually true. Studies reveal that recovered women often give a lot of credit in their recovery to a supportive partner, but without a sort of vehicle to help that spouse or partner get online with their client, the eating disorder can create a lot of stress and a lot of distance in a relationship, in the same way it can with families, if we don't bring that support person into the treatment modality, clarify their role, and give them some, not only psychoeducation, but make them feel a part of the process. So it basically formalizes the role of each of the partners to help facilitate recovery. Okay, and the very last thing I'm going to talk about very quickly before we open it up for questions is to talk about emotion-focused family therapy. And this is also an adjunct treatment. And I really just cannot say enough about how much I love emotion-focused family therapy, otherwise known as EFFT, because the tools are useful in, I would say, pretty much every area of your life. As a parent, as a clinician, anyone who could potentially find themselves in situations with upset people can benefit from the tools in emotion-focused family therapy. Basically, it recognizes that the eating disorders themselves put family members in a very difficult position, and it can really divide and conquer, creating a lot of resentment and fracture. So EFFT trains the parent to be the client's emotion coach. And as the eating disorders are a main vehicle of disconnection from emotions, this emotion coaching piece, once the parents are empowered with it, really creates a lot of healing. It creates a lot of, emotional closeness, because the parents are given the tools to feel like, whatever happens, whether the client is having a very bad day or very upset about a particular meal, is feeling overwhelmed, if they're seeing explosive behaviors, the parents know what to do in identifying the emotion, validating the emotion, and helping walk the client through a process that is really quite empowering and enlightening for both the parent and the client. There is a really great website, which you will get a link to, and also a really good book by one of the researchers. It's called What to Say to Kids When Nothing Seems to Work. And it does go through all the steps of emotion coaching. I will say on the back of the book, it says, for children through 5 to 12. But again, you can use these skills with any population, cradle to grave. So I am looking at the time, and this pretty much wraps it up. I do want to apologize again. I'm sure a lot of you can really empathize with my lack of technological skills. So apologies that you had to look at me and not the slides the entire time. But I am very happy to, it is in Allison's hands. She can send it along to all of you, and I'm happy to open it up to any sort of questions or comment or discussion from the audience.
I'll go ahead.
Sorry. I just want to say that your presentation was excellent and very, I was taking notes the whole time, and I was very interested in everything you were saying. I was just wondering, are you going to be doing more presentations by any chance?
That is a really good question. I don't really know. But one thing that I did want to put out there is that I have been doing a consultation group for myself and a few of my colleagues. We meet about once a month. And so if there are any people who are here today that would be interested in joining a consultation group, I find it's a wonderful format where everybody can learn from one another, because everybody who comes to that consultation group has got a lot of their own skills. So maybe you can email Allison at Family Service Windsor. You can email me directly, j.white@paragonpsychology.com, if you are interested in a consultation group, and I would be happy to put something together. I love doing those.
Perfect. Thank you so much.
You're welcome.
The question I have is, could you give an example, please, if you were at the family dinner and the client had moved out of that safe food or introducing new foods, and you were dealing with that reaction and dynamic? What would that look like?
Like something sort of explosive, for example.
Yes, yeah, you talked about this when you observed the family dinner, and
Mm,
you just touched on quickly that you're watching for um, reaction, or something's threatening, I guess, to your client. How would you move in and respond with that and work with that?
good question. So one, you know, I guess one alteration that I think maybe, should be made or revisited in family-based therapy, this is knocked around in my head and I've never followed through on it, is that it should almost be done, the family meal should almost be done further down the line in treatment, because I do find depending on the logistics, doing the family meal in the first or second session, that everybody is on their best behavior. So I'm not sure I really get a very accurate viewpoint. Like typically everyone will just eat exactly what is on their plate, and just get through it because the therapist is there. So oftentimes I see like the really rosiest version, but occasionally there is, a bit of, again, explosive sort of eating disorder behavior, which is defensive. And so generally speaking, it will sort of depend on what I'm seeing. But overall, I'm looking more so at the parents and if they can stay calm and breathe through it. So, I generally speaking will encourage both of the parents to be right on either side of the client. And if the client is struggling, to actually get in very, very close proximity. So very little in the way of personal space. And the reason I do this is that we had to sort of do it when we were in the training. And my experience of being the client in the training was that when I had my parents on either side of me, being very positive, very encouraging, it was very difficult to not eat or to maintain any kind of resistance. So, I'm looking for the parents. I will direct them to be very calm, very positive, very encouraging, and be very physically close to the client to sort of give them that comfort and almost, like calm the eating disorder and get it to dissipate. There are some other strategies where, I will encourage the parents just to get the kid to take maybe one more bite than they had planned on. I will direct the parents to encourage the client to maybe not put their fork down or their knife down, like keep their utensils, that sort of thing. But it's pretty rare that I have to get too nitty gritty because, as I say, I think I see a rosier picture typically than what usually happens.
Thank you.
Jennifer, we have a question. What sort of strategies do you recommend to a physician to use in the initial phases while patients are waiting to be seen at Banna? I usually jump to address the comorbidities as you mentioned.
Okay, so can I clarify? So this is somebody in a medical role, I'm assuming, right?
Could be.
Yes,
Okay.
it's me. I made the question if you want me to speak. So you mentioned don't address the comorbidities first, like the anxiety, depression, but then we are not specifically trained to help with the eating disorder side. So what do we do for our patients while we're waiting, while they're waiting to be seen, which could be up to 8 weeks to 12 weeks, depending on the wait list?
Mm-hmm. I think, well, I guess it would depend if the client is at an ideal body weight. So if they're stable or they're not stable. So if they're medically stable and they are, and of course, that is outside of my scope of practice. So generally speaking, if somebody is already at an ideal body weight and the disease is not incredibly derailing their life, it might actually be appropriate to do a little bit of work on the depression or the anxiety because it can't hurt. However, if that person, maybe they get into treatment with, a community provider or private practice clinician, you would encourage them, like once you start at Banna or once you start at Teen Health, put that other therapy on hold. Do not try to do both. It's way too confusing. It's way too overwhelming, but any form of support can be really great for the clients while they're waiting, while they're sitting there on a wait list. The other thing that is good to know is that, especially in the pandemic, netic.ca has widen the scope of their virtual support services that they're providing. So clients can, I think it's 9 a.m. till 9 p.m., 5 days a week. I think the weekend hours are slightly shorter, but they can call, they can chat, they can email Netic and get support in the meantime. There are volunteers that are always there. And there's also a lot of online support as well, or even, peer support groups. Those can be a little bit dicey, but if the client is an adult, they probably have good insight as to whether or not that group might be a good fit for them. So it's not a bad idea to get support in the meantime, but just understanding that normalizing the eating must be a treatment priority once they get into the services that they require.
Thank
A
you.
couple of other questions if we have time, Jen. From Sarah, thank you, offering gratitude, very helpful to learn more about FBT, and would be interested in learning more about transitioning clients from FBT to CBTE as they become quote unquote legal adults and the treatment transitions to more independent and families becomes less hands-on. Do you want to comment on that?
Sure. So FBT, it's interesting. I was just also listening to a podcast, which is a great podcast. Can't recommend it enough. It's called ED Matters. It's available in, Apple Podcasts and whatnot. So they had just done a 3-part series on multifamily groups for young adults. And it is basically a family-based therapy modality to be done in groups. Now, back in the day, I know there was some of the research actually occurred at U of T in partnership with a group of researchers in Norway. And it was especially helpful in Norway because you've got people in remote areas. And so they would come together. For these weekend sessions. So, very long-windedly, a family-based treatment structure can be used even for young adults or after, the age of 18. And I think it really does depend on the client and their family structure. So if we've got a young, even a teenager who's operating very, very independently, CBTE from the outset might be a better fit for them. But if you've got a client who's very close with their family and they are in, even in their early to mid to late 20s living at home, I do like to, in that case, I'm just thinking of a 26-year-old client I have right now, where from the beginning, we did a split session. So we did the first half of the session as family-based therapy, and the second half of the session, because my client was 26 when she started treatment, the second half of the session was done with her. And then once she was weight restored, we just then proceeded on with only individual sessions, and her parents might still come in, once a month or once every 6 weeks, just to sort of see how things are going and give them an opportunity to address, any sort of, things that they're seeing that they might be concerned about, or anxiety that the parents are having. That's a big thing that I sort of see after the client is better. The parent almost needs their own treatment for sort of like post-traumatic stress symptoms after the eating disorder. But a family-based modality can also allay some of those concerns. So I think a split session oftentimes works really well. It also works well in families where we have younger clients, but high expressed emotion.
Another question, how do you handle difficult families who are abusive towards the patient, or are the majority of families more than willing to cooperate? An example could be that the patient's eating disorder is stemming from problems at home.
Mm-hmm. So in that scenario, it is not appropriate to do family-based therapy if we actually have, an abusive situation happening. So if there's any sort of physical abuse in the home, we're looking for CAS to get involved and make sure that all safety concerns are taken care of first and foremost. But I do find that most parents are, if it's gotten to the point where they have gotten into my office, typically it is the parents who have initiated treatment when it comes to family-based therapy. Almost never is my client actually willing, and the therapeutic relationship or rapport is not something that I am at all concerned about in the early days. I probably should have mentioned that as well in family-based treatment. That comes later on down the line. What I might see is parents getting very frustrated and exasperated, and the difficult family would be more of what I would characterize as the high expressed emotion family, where a parent might start to get overwhelmed and really, go down a road that is quite triggering or not really appropriate and can sort of cause damage. And that's where we use the emotion-focused family skills to give the parents things to do instead and to walk them through, more proactive and positive parenting strategies.
All right, thank you. And finally, what are your thoughts about starting trauma work while waiting for ED treatment, inpatient setting, meaning not medically compromised?
If the client is medically stable, I think, myself and some other clinicians have found, well, I think, it can definitely be done. But so there are a couple of ways to go about this. One of them being understanding that if there is trauma or complex trauma in the client's history, the eating disorder is a part. So we have to kind of make sure that all parts are on board. So if the eating disorder part is stuck in trauma time, trying to, it kind of has to be integrated. So you just want to be cognizant of the fact that if the eating disorder is a protector part, it can get triggered by trying to address the trauma if the eating disorder gets threatened. Does that make sense?
Mm-hmm.
So it's like, you gotta, sometimes stabilizing the eating disorder is helpful, but that can also become very complicated as well. So I don't know if that was a very comprehensive answer.
And one final question. Have you found a rise in eating disorders or requests for help relative to the pandemic? How have you seen the impact of COVID-19 affecting individuals living with an eating disorder that you have worked with?
This is a very good question. And this is part of why we're doing this Coffee with Colleagues first, is that, so not only were the clients who had eating disorders prior to the pandemic very compromised by the circumstances that we have seen, it did give rise to, I believe that there are all kinds of adolescents in particular that have eating disorders today that would not have had the pandemic not happened. I don't know if anybody saw it, but just in the last couple of days, CBC did an article on the rise in eating disorder requests that we've seen. I've actually just now changed my, admission criteria to my practice, as I am only seeing eating disorder clients now. So if somebody wants to, get on my waiting list and they don't have an eating disorder, I've instructed the front desk to refer them out to somebody else, because I feel like we are in an eating disorder pandemic as much as we are in a COVID-19 pandemic. And there are several other eating disorder clinicians who are here on this call, so I would be interested to hear from them too. We've seen numbers just the likes of which I have never seen.
There's some comment in the chat about 100% agreement with you in terms of the increase. And we've also had lots of thanks directed to you, Jennifer.
Oh, well, you're welcome. I apologize again about the slides.
Okay, we are at 10 minutes after 10. For those of you who have to move on to your next meeting or work, we certainly understand. We will make sure to get the PDF of Jennifer's presentation out to you. And if there are no other questions, again, lots of gratitude, lots of thanks, valuable information. We notice the connection between the research and the evidence base with regards to your recommended treatment practices.
Well, and thank you everybody for coming and taking the time out of your day. This is an area that at Banna and Teen Health and myself, we're very, very passionate about and very positively encouraged to see all of you joining us today. So thank you so much.
Thank you, everyone. Take care. Be well.